So, hello everybody. My name is Dr. Amar Shah. I am a neonatal and pediatric surgeon working at Amardeep Multispeciality Children's Hospital in Ahmedabad. At the outset, I would like to thank the team of IFPP for giving me this opportunity to talk on congenital malformations of the lung. So, let's start the talk now. So, congenital malformations in the lung are detected more frequently during high-resolution prenatal ultrasounds. And nowadays, we get lots of parents who come with antenatally detected problems in their child's lungs. When this is missed, they usually get detected in the neonatal period or in the infancy. However, some lung malformations may also be picked up in later childhood or even in adulthood, and the diagnosis may sometimes be confusing. So let's come to the embryology. The lung basically develops in 5 stages. It starts as early as the 3rd week of intrauterine life, when there is the embryonal phase. And in this stage, the formation takes place up to the lower bronchi level. The next is the pseudogranular phase, which is between 5 and 16 weeks, when the development of all the bronchioles takes place. Then comes the canalicular phase, which is between 16 and 24 weeks, where the epithelium differentiates and distal acinar development takes place. The next is the saccular phase, which is between 24 and 36 weeks, where the alveoli and the terminal sacs develop. And the final phase would be the alveolar phase, which happens after 36 weeks, and it's predominantly a phase of maturation. So the congenital lung malformations can be classified into 3 broad categories. The first is bronchopulmonary or lung bud anomalies. The second is the lung and the vascular anomalies. And the third is just the isolated vascular anomalies. Now the main chunk of anomalies would be the first group, that is the bronchopulmonary anomalies. So I've just enlisted the bronchopulmonary anomalies. These are congenital bronchial atresia, congenital lobar emphysema, congenital cyst adenomatoid malformation, bronchogenic cysts, tracheal bronchus, accessory cardiac bronchus, tracheomalacia, tracheal stenosis, and pulmonary underdevelopment. So now we'll discuss each of these pathologies in a bit of brief detail. So coming to the first problem, which is congenital bronchial atresia. Now, bronchial atresia happens because of focal obliteration of the proximal segmental or the subsegmental bronchus. It mostly affects the segmental bronchi near their origin. There is no communication between this segment and the central airway. The distal structures are, however, normally developed, and the bronchi distal to the stenosis get filled with mucus, hence forming a bronchocoel. Now, this happens because, as I said, there is no communication with the central airway, and hence mucus gets collected, forming what is called a bronchocoel. Bronchial atresia may also happen after birth, that is, it can be postnatal, and it can be because of either trauma or a inflammatory pathology. 50% of these patients may be asymptomatic, and it may also be an incidental finding in young adults when an X-ray chest has been done for an unrelated condition. It may also cause symptoms like dyspnea or pneumonia. Now the workup includes an X-ray of the chest, which shows a bronchocoel, wherein it has rounded branching opacities radiating from the hilum. A contrast CT scan of the chest is a confirmatory workup, which shows a round opacity at the site of the atresia, which is medial to where the air is trapped. Treatment includes lobar resection or a segmentectomy, but it is offered only in patients who are symptomatic. This is the X-ray, which shows a bronchocoel, and a CT scan, which again confirms this pathology of congenital bronchial atresia. So coming to the next anomaly, which is congenital lobar emphysema or CLE. Now, this is very commonly seen and it forms almost 50% of all congenital lung malformations. Here, there is a progressive over-distension of a lobe of the lung. The air trapping in the emphysematous lobe may be because of a dysplastic bronchial cartilage which creates a ball valve effect, an endobronchial obstruction from inspissated mucus or extensive mucosal proliferation, extrinsic bronchial compression from an aberrant cardiopulmonary vasculature or enlarged cardiac chambers, and diffuse bronchial abnormalities may also be a cause of congenital lobar emphysema. Associated cardiovascular anomalies may be up to 15% in these cases. Most of the patients between the age of 0 to 6 months are symptomatic. However, patients may be asymptomatic, and this may be an incidental finding when an X-ray is done for an unrelated cause. Now, lobar emphysema, the left upper lobe involvement is the most frequent, which is almost 40 to 50%. The right middle lobe comes next, which is seen in 30 to 40% of the cases. And then comes the right upper lobe and the lower lobes. An X-ray of the chest is mostly diagnostic for this pathology, where it shows an overinflated and hyperlucent lung on the affected side. This may cause a tracheal or a mediastinal shift. It may also cause atelectasis in the adjacent lobes because of the compression of the hyperinflated lobe. A CT scan with contrast is the gold standard for establishing the diagnosis. It not only evaluates the anatomy, but also assesses the adjacent and the contralateral lobes, and it also helps delineate the vascular compression, if any, because sometimes a vascular compression may also be a cause of CLE. Radionuclear scans have been done. They, however, just show a non-functional lobe, and they are rarely used. So this is the X-ray showing a right hyperinflated lung in a CLE. The CT scan again shows a right hyperinflated lung, and a small collapsed lobe is also seen down here over the medial part. This is of course the normal lobe which has got collapsed because of the hyperinflated pathological lobe. No sooner we open the chest for operating children with lobar emphysema, the emphysematous lobe juts out of the incision because it is just searching for place where it can expand. Lobectomy is curative for this pathology, and the long and the short-term prognosis are excellent. So coming to the next pathology, congenital cyst adenomatous malformations. This is an uncommon cause of respiratory distress in neonates and infants. It happens because of overgrowth of the bronchioles with almost complete suppression of alveolar development. The communication between the individual cysts within the cecum and the tracheobronchial tree, it occurs with equal frequency in the upper and the lower lobes. However, it is mostly unilobal. Now, cecum can be classified into three types. Type 1, which is the most frequent, 70%, wherein one or more cysts are more than 2 cm in diameter. It is surrounded by multiple smaller cysts, and it is lined by ciliated columnar epithelium. This is called a macrocystic variety of cecum. The second type, which is seen in 15 to 20% of the cases, is where the cysts are less than 2 cm in diameter. They are lined by cuboidal or columnar epithelium, and in this type, associated renal and cardiac malformations may also be seen. In the type 3, which is the microcystic variety, the cysts are less than 0.5 centimeters in diameter. They are lined by cuboidal epithelium, and they are rarely seen postnatally. The type 3, however, has a poor prognosis. These are X-rays showing congenital cyst adenomatous malformation. This is the macrocystic variety. This is the large cyst which is seen, and in the CT scan, you can see the multiple cysts. This is the X-ray, and these are the CT scans which shows cyst adenomatous malformation. So coming to the management. Management is a bit controversial in asymptomatic cases, as some people do suggest a non-surgical line of management in these cases which are asymptomatic. And if at all surgery is needed, when should it be done is again a gray area. For symptomatic neonates and in older children with recurrent pneumonia, surgery has to be done and it is completely curative in this pathology. The risks of non-treated cyst adenomatous malformations are infections and malignancies. The different types of malignancies that are seen in untreated CCAMs are enlisted, like bronchogenic, bronchoalveolar carcinoma, pulmonary blastoma, and even rhabdomyosarcomas. So this is the operative specimen. A thoracotomy was done, and here you can see the lobe of the lung with multiple cysts, and this is how a cyst adenomatous malformation looks like. So the next bronchopulmonary abnormality is a bronchogenic cysts. These cysts normally originate in the abnormal diverticuli of the lung bud. It is usually extrapulmonary and it is located adherent to the left main stem bronchus or the carina. Bronchogenic cysts are the cause of almost 50% of all mediastinal cysts. The bronchogenic cysts may also be intraparenchymal, and they are caused by abnormal budding in the distal tracheobronchial tree. These may, however, be more on the right side. The cyst wall contains all the elements of a normal bronchus. Again, it may be an incidental finding or it may cause respiratory distress. Sometimes bronchogenic cysts may also get infected, and it may be a cause that can be identified when the child develops symptoms of infection. Complications include infection, hemorrhage, erosion into the adjacent structures, and malignancy. X-ray chest is diagnostic in almost 75% of the cases. A CT scan of the chest defines the exact site and the size of the cyst. When a contrast is given, the cyst does not enhance, and it helps in identifying and clinching the diagnosis. The treatment is surgical excision regardless of the age at presentation, and nowadays bronchogenic cysts can also be excised with minimally invasive surgery or video-assisted thoracoscopic surgery. This is the X-ray which shows a left retrocardiac bronchogenic cyst. Needs an expert radiologist and a close eye to sometimes pick up these lesions. As I said before, CT scan helps in clinching the diagnosis of this congenital problem. So coming to the next problem is a tracheal bronchus. This is a relatively rare anomaly. Now the bronchial anomalies arising in the trachea or the mainstem bronchus may cause a tracheal bronchus. It is usually in the right lateral tracheal wall and less than 2 centimeters above the carina. It may involve the entire upper lobe or its apical segment. This may be an asymptomatic problem, or it can cause recurrent upper lobe pneumonia or atelectasis. Diagnosis again is by CT scan or a bronchoscopy. Treatment is mostly conservative, and excision of the involved segment may be required if it produces symptoms. Next is tracheomalacia. Tracheomalacia is softening of the tracheal wall due to cartilaginous abnormalities. The causes can be secondary to tracheostomy, esophageal atresia with or without tracheoesophageal fistula, chronic inflammations like cystic fibrosis or recurrent aspirations, extrinsic compressions by vascular rings, slings or aberrant vessels, and neoplasms. The symptoms: the child normally presents with an expiratory wheeze. Fluoroscopy shows an exaggerated reduction in the sagittal width of the trachea during expiration. A CT scan can be done to access the cross-sectional anatomy. Most of these children do not require any treatment because they may be just asymptomatic. However, in severely symptomatic patients, the treatment of the primary cause, if any, should be done. Sometimes these children may also need tracheal stents or aortopexy. So we now almost reaching the last of the bronchopulmonary anomalies, last few. Tracheal stenosis. Tracheal stenosis is the congenital stenosis due to complete cartilaginous rings in the trachea. This is quite a rare problem. 50% may be just a focal tracheal stenosis, 30% may be generalized, and 20% may have a funnel-shaped stenosis. 90% of the children present in the first year of life with biphasic stridor. A CT scan and an MRI with angiography and bronchoscopy may help to diagnose this complex problem. Treatment may include endoscopic dilatation. However, repeated dilatations may be required in children who become resymptomatic. Reconstruction of the tracheal stenosis with or without a cartilage graft, resection of the isolated segment and end-to-end anastomosis, or a tracheoplasty can be offered for children who are symptomatic. So now we come to the last of the bronchopulmonary anomalies, which is pulmonary underdevelopment. Now there are three types or three varieties of pulmonary underdevelopment. One is pulmonary agenesis, second is pulmonary aplasia, and the third is pulmonary hypoplasia. Now, agenesis is a problem where the bronchus, both the bronchus and the lung are absent. Pulmonary aplasia is where the bronchus is rudimentary, but the lung is not present. And hypoplasia is where there is bronchial hypoplasia and variable reduction in the lung tissue. Pulmonary agenesis is commonly seen with other associated congenital anomalies in almost 50% of cases, which include cardiovascular, gastrointestinal, urinary, and skeletal systems. An X-ray helps to diagnose pulmonary agenesis or aplasia. X-ray shows a diffuse opacification of the involved hemithorax with ipsilateral mediastinal shift. A CT scan confirms the absence of the lung parenchyma, bronchus, and the pulmonary artery on the affected side. Imaging in pulmonary aplasia is similar except for the presence of a short ending bronchus. So, when there is agenesis or aplasia, the imaging is almost similar apart from a short ending bronchus. This is an X-ray which shows pulmonary agenesis on the right side, a complete opacification which is seen in the right hemithorax. This is again confirmed on the CT scan. Pulmonary hypoplasia may be picked up on antenatal imaging. Here, the thoracic circumference is below the 5th percentile for the gestational age. A few other ratios have also been shown to help diagnose this condition, like the chest to the trunk length ratio, if it is less than 0.3, and the femur length to the abdominal circumference ratio, if it is less than 0.16, then pulmonary hypoplasia may be suspected. It can be either primary or secondary. Primary when there is no definite cause for it, or secondary when there are intrathoracic lesions like diaphragmatic hernias or space-occupying lesions inside the chest, or extrathoracic problems like severe oligohydramnios, which may be seen in genitourinary anomalies or skeletal dysplasias. Just a quick 2 slides for congenital diaphragmatic hernia, because this is an important pathology which cannot go without discussing when we are discussing pulmonary hypoplasia. So I've just kept 2 slides of congenital diaphragmatic hernia here. So congenital diaphragmatic hernia can be of 3 types. The left posterolateral, which is the commonest. However, it may be seen on the right and bilateral. The anterior type, which is called Morgagni, and hiatus hernia. Now, congenital diaphragmatic hernia is commonly associated with pulmonary hypoplasia. Preoperative stabilization and control of persistent pulmonary hypertension is vital for a successful surgical outcome. These are a few X-rays showing diaphragmatic hernia. This is the classic left diaphragmatic hernia. This is a right-sided diaphragmatic hernia. This is bilateral diaphragmatic hernia, and the anterior, which is the Morgagni diaphragmatic hernia. So this ends our first group of congenital lung anomalies. Now we come to the second group, which is the lung and the vascular anomalies. This is a relatively small group, and it contains mainly 2 pathologies. First is bronchopulmonary sequestration, which could be intralobar or extralobar, and hypogenetic lung, which is also called scimitar syndrome. So let's discuss pulmonary sequestrations. Now here, a segment of the lung parenchyma receives its blood supply from the systemic circulation, which can be either from the abdominal or the thoracic aorta. The sequestered lung does not communicate with the normal tracheobronchial tree. It can be of two types, that is intralobar, which is seen in 75% of the cases, where it shares the visceral pleural covering of the normal adjacent lung, or it can be extralobar, which is the remaining 25%, where the entire sequestered segment is separate from the normal lung tissue and it has its own pleura. Now, they are commonly located in the posterobasal portion of the lower lobes, and this is the most common site of pulmonary sequestration. Now, let's discuss intralobar pulmonary sequestration. It is mostly diagnosed on prenatal ultrasound scan. Associated congenital anomalies may be in about 6 to 12%. Intralobar sequestration may be associated with neonatal cardiac failure. It is usually diagnosed in the late childhood or even sometimes in adults. It can be incidental and it may be picked up when workup is done for recurrent pneumonia or even hemoptysis. The diagnosis which clinches this is imaging, of course, and feeding systemic vessels are always seen, which are either coming from the thoracic or the abdominal aorta, and this feeds the sequestered lung. On the other hand, extralobar pulmonary sequestrations, they can be picked up on antenatal imaging because it may be a cause of polyhydramnios or high output cardiac failure. Associated congenital anomalies may be seen in almost 50% of cases, which may include a congenital diaphragmatic hernia, CCAMs, etc. It is usually diagnosed early and it may be either an incidental finding or it may be in the pre or postnatal imaging. Infants may present with respiratory distress or even feeding difficulties. Imaging is, as I said before, is diagnostic in pulmonary sequestrations. Ultrasound scan with color Doppler can help suspect this problem. CT scan is diagnostic where it identifies the structure and the vascular supply. It helps identify whether the sequestration is intralobar or extralobar and also the vascular supply. Sometimes MR imaging and angiography may be required to identify the feeding vessels. Extralobar sequestration can be easily resected in an isolated segment. However, intralobar sequestrations may require a segmentectomy or a lobectomy. Sometimes embolization of the feeding vessels has also been done as a treatment modality for pulmonary sequestration. So this is the imaging, and here, this is the descending aorta. And you can see there is a nice branch which is coming from the thoracic aorta and entering the pulmonary sequestration. And this is the operative specimen. This is the sequestered segment. This is of course an intralobar sequestration, and this is, as you can nicely see, the vascular supply which is coming from the aorta into the sequestration. Here, a lobectomy was needed to be done for the sequestration. So the next problem is a hypogenetic lung, which is also called scimitar syndrome. Here, the features are of lung hypoplasia. However, the ipsilateral pulmonary artery is hypoplastic and the lower thoracic or the abdominal aorta supplies the right lower lobe. It may also have an anomalous pulmonary venous drain return where the pulmonary veins drained into the inferior vena cava. The infants of hypogenetic lung present early when it coexists with any other congenital heart disease, and it is associated with the high morbidity and mortality. And these kids are more likely to develop pulmonary hypertension. The diagnosis is done by an X-ray chest. A CT scan and MRI may be required for direct visualization of the anomalous veins. A conventional angiogram may also help to delineate the vascular anatomy before a surgical repair is carried out. Now coming to the last group, vascular anomalies. Vascular anomalies may be either the absence of the main pulmonary artery, anomalous origin of the left pulmonary artery, anomalous pulmonary venous drainage, or pulmonary arteriovenous malformations. Echocardiography is recommended to assess the cardiac anatomy and look for associated defects. A CT scan or MR angiography accurately depicts the hilar anatomy and delineates the collateral vascular network. And it is only after this that a management protocol can be carried out for these patients. So to conclude, for congenital lung anomalies, only a few cases may be there where a firm diagnosis can be made solely on clinical grounds. Most of the congenital and developmental anomalies have characteristic imaging features, and imaging of the thorax and abdomen should be obtained as soon as possible if you are suspecting a congenital lung problem, because without imaging, diagnosing of these lesions may sometimes be difficult. So thank you all.